today we are going to discuss an andrology case, and in this process of discussing this case, we're going to go through the patient's journey and we're going to learn a lot of things about operative andrology with respect to the erectile dysfunction. So let me begin this case. This is a 32-year-old gentleman. He is presented with difficulty in erections. This, we already know that this is something which we call as erectile dysfunction, and basically this has been there since he got married, which is 1 year. That's what the patient says, that he has been having it for the last 1 year. He's been married for the one year and he's not been able to consummate the marriage. Now, what would you like to know further in this case? What will you ask this patient if this patient came to you and said that he was not having any relations with the partner? So, one is to know the real duration of when the problem started, because many times patients, when they are with their partners, they would shy away, would not like to tell the real problem. So, you have to privately ask the patient what was the real duration. In this case, the real duration was 12 years. So, this is a long duration erectile dysfunction. Also, we need to know exactly what is the level of blood supply within the penis, what is the quality of the sponge that is there. And for that, we need to really assess the erectile hardness score in a very objective way. So, we have to know what is the erectile hardness score. Now, erectile hardness score, there are 4 sponges that are there, and the patient can, just feel those sponges, and then based on that, it could be grade 1, 2, 3 and 4. Now, EHS, we already know that grade 1 is when there is only some enlargement of the penis, but there is no erection. Now, grade 2 is when there is an enlargement plus an erection, but it is not sufficient for penetration. And then grade 3 is when there is an erection, but it is not the strongest. Here the patient can penetrate a non-virgin partner, and grade 4 is when it's the best erection, where the patient is able to penetrate. So, grade 3 and 4 are both considered as normal erections, but you have to understand that not only this, the timing for which the erection remains is also very, very important in this history. So, we have to ask this patient about premature ejaculation also, or any other associated sexual dysfunction or ejaculated dysfunction or orgasmic dysfunction. We have to ask the patient. And then we do a local examination. So, what do we do in the local examination is that we see for the secondary sexual characters. We look at the external problems like phimosis or any foreskin issues, or we look at a tight frenulum which could be causing pain and therefore there could be sexual dysfunction. So, these are the local things that we would like to see. So, this is the initial evaluation. Now, what do you do? What you do is that once you evaluated the morning erections, you evaluated the erectile score of the patient and the amount of erection that the patient is getting, and you're able to judge the duration of this problem, associated problems, then you give a trial of something which we call as the phosphodiesterase 5 inhibitors. Now, what are these phosphodiesterase 5 inhibitors? They could be sildenafil, that could be tadalafil, it could be avanafil, or it could be udenafil. These are all available in India. So, we should know about all the 4 drugs, and then you give any of them to this patient and you ask them to come back and tell the effect of the medication that the patient had. Now, basically the patient was given phosphodiesterase 5 inhibitors as we've discussed, but when the patient came back, he was not happy. He said that there is no response to this medication. In fact, he developed myalgia and headache. Now, again coming to the discussion in this live session, why does myalgia happen when we give phosphodiesterase 5 inhibitors? That's because of the cross sensitivity of phosphodiesterase 5 inhibitors with phosphodiesterase 11, wherein it can lead to some muscle soreness, and sometimes this myalgia can be very, very severe enough to not continue with phosphodiesterase therapy. This typically happens with tadalafil. So, this is another question that I want you to know. Headaches develop because of vasodilatation, but also patients can develop something called blue vision. Now, this blue vision happens because of cross-reactivity with phosphodiesterase 6, and this is specifically there with sildenafil. So what is the further evaluation which is needed in this patient where you've tried giving a phosphodiesterase inhibitor but it did not work for the patient? So first is that one, there is some sort of an organic cause, because typically if it was just a very mild erectile dysfunction, it would have responded well to the phosphodiesterase 5 inhibitors. Now since it didn't, so we should look at some other problems that the patient may have which could be leading to an organic erectile dysfunction. For example, diabetes. So we could do an RBS or a HbA1c. It could be a dyslipidemia which could be contributing, so we will have to do a lipid profile. Also, we need to look at the testosterone levels of this patient, because this total serum, total testosterone, it has a direct impact on the action of phosphodiesterase 5 inhibitors. In case there is a low testosterone, then our phosphodiesterase 5 inhibitors are sometimes not going to give any benefit to the patient. So we should always check for testosterone levels once we have a patient who is not responding to the phosphodiesterase inhibitors. Now, apart from this, we can also go for certain radiological investigations. So what are the radiological investigations? We can go for something which we call as the penile Doppler study. In this, what we are doing is that we are going to look at the levels of flow in both the cavernosal arteries. So this is the cross section of the penis, and we are going to scan this artery and this artery on the right side and the left side, and we are going to basically look at the waveform. So we are going to comment on the peak systolic velocity and the end diastolic velocity, and sometimes the resistive index. Now typically, to call it an organic erectile dysfunction, the PSV has to be less than 25 and the end diastolic velocity should also be more than 5. Typically, penile Doppler requires intracavernosal injection with papaverine, or sometimes an oral sildenafil of 50 milligrams to 100 milligrams. So these are all other important questions. So in penile Doppler, we are giving 2 ml of papaverine, which effectively is about 60 mg of papaverine, or we are giving 100 mg of sildenafil citrate. Now basically, what are the other further clinical evaluations that we could do? We can do something which we call as office sildenafil test. In this, again, we give the patient 50 to 100 mg of sildenafil and we ask the patient to self-stimulate in an isolated room, and we try to see what is the level of erection that the patient is obtaining. Apart from that, we can also do an office ICI VAD test, which means that we can give an intracavernosal injection of vasoactive drug. Now, these could be papaverine, again, as we will give in the penile Doppler, or it could be Biomix, or it could be Trimix. Now let's move ahead. Let's see what happened to this patient. So there was a poor response to all the medications that we were giving, including the combination therapy. So whenever the patient is not responding to phosphodiesterase 5 inhibitors, we can either check the testosterone, we can supplement the testosterone, and sometimes we can give more than one phosphodiesterase inhibitor. So typically what we are using is tadalafil on a low dose basis, plus we supplement it with sildenafil on an SOS basis. Plus, we can give either SERMs, which are selective estrogen receptor modulators like clomiphene citrate, or we can give aromatase inhibitors like letrozole or anastrozole, or we can directly supplement testosterone if the patient is not desiring fertility, is in an age which is elderly age, and we know that we can directly give testosterone safely without affecting the fertility of the patient. So they have tried everything. Now the couple is considering a divorce. Now what does it imply if the couple says that they want to go for a divorce? It makes this condition a semi-emergency. So basically now we have to deal with the couple in a more proactive way, in a faster way. We just can't let the couple go and come back again, because then they may not come back. So what are the treatment options and the further evaluation in this case? Of course, we have discussed already the evaluation that we would need initially, but what we also want to know is if there is any problem with the wife. So of course, vaginismus is an important thing. Also, we have to do a psychiatric, or we can say psychosexual counseling for the couple. And we can go for advanced tests, like we can go for cavernosometry if we are suspecting a venous leakage. What are the treatment options in this couple? Of course, we can offer this couple a ICI VAD. ICI VAD, again, as we discussed, it's about giving some sort of a vasoactive drug into the corpora cavernosa. Now, this could be bimix, which is a combination of papaverine along with phentolamine, but since it's not available in India, so we also use chlorpromazine. Or it could be trimix, which means that we will mix bimix with alprostadil. So, we give some amount of this into the penis directly, and we don't give the full dose. We start with a very low dose initially. It was a young couple. We were thinking mainly of a psychogenic erectile dysfunction. Because of the long history, we were also thinking of this being an organic erectile dysfunction. But as we can see, this patient is not responding very well to any of our therapies, which clearly means that it is not a simple case of psychogenic erectile dysfunction. There has been some evolution into organic erectile dysfunction as well. Now, what are the other options that we could offer to this patient is PRP. So, we want to discuss PRP here as well. So, PRP means that we are giving a platelet-rich plasma. Now, platelet-rich plasma therapy is not a standard therapy for patients with ED. So, it is not to be mentioned too much and not to be selected as an option up till now. It's experimental, which means that there are a lot of trials which are going on in this, but we have not been able to find a sufficient clinical evidence to recommend the use of this therapy for erectile dysfunction. But still, we should know the basics of it. So, the basics is that we are going to supply the rich growth factors for neoangiogenesis within the penis, and this is being given through the platelet-rich plasma, which has a lot of growth factors, as we know. The third option that is being given to this patient is LIESWT, which is low intensity shock wave therapy, which means that we are giving focused sound waves onto the penis, and these are going to create new vessels in the penis so that the vascularity of the penis improves. Now, low intensity shock wave therapy, again, it's not something that you would like to mention as an answer because it's still an experimental therapy, although the level of recommendations are better for LIESWT than PRP. But you have to understand that it is still not something which is proven. In fact, if you look at the guidelines, if you look at the European guidelines, there are some guidelines which discourage the use of low intensity shock wave therapy as a main line of therapy. These type of therapies are only given in patients with mild arteriogenic or vascular impotence. So, this is something that we need to understand. Now, last option that is there in this question is the prosthesis. So, prosthesis means that we are going to put an implant into the corpora cavernosa so that there is always some sort of a stiffness on request or otherwise depending on the implant, and the couple is able to perform. Now, considering that there is a poor response in this scenario to all the medications till now, including the combination therapy, the couple is considering a divorce and it's already a semi-emergency. The treatment option would be a ICI VAD in the first place. Why it would be ICI VAD? Because the penile prosthesis is going to be a tough decision in the sense that it's going to have its own consequences. It's an irreversible procedure. Once you have put the implant, then you cannot go back to the original state. So, you would like to first start something which is the least invasive for the couple. And what is the least invasive? That's the intracavernosal injection of vasoactive drug. So, what you will be doing it is first you will check the dosage that will be needed by the patient. You will be injecting it in front of the wife and teaching the patient how to inject it into the penis themselves. Just like the diabetics, they take insulin injections, these patients will be taught how to use the intracavernosal injections themselves. And whenever there is a requirement, whenever they have a sexual activity planned, it can be given just 5 minutes prior to the sexual activity or 10 minutes prior to the sexual activity. Now with that, the couple may be able to at least consume the marriage, and that is going to take the expectations of the couple to a new level. We are going to go away with the semi-emergency situation, because the couple will have consummated and their patient, the psychogenic component, would have a blow, because they will be able to consummate, and then the patient will get a confidence that he can consummate again. And many of these times when the couples, they have a strong psychogenic component, giving the ICI VAD therapy can be a boon, because it will make the confidence levels reach a new height, and the patient would then be able to overcome their anxiety to perform. And then basically further on they would be managed better with the medications, because the psychogenic component would reduce significantly. Now let's see, once we've given the ICI VAD, what happened to this patient. Now in this patient, we tried the ICI VAD because that was the next choice, but he was asked to try going home and consummating and then come back if the patient is not able to get flaccidity in the penis. Now this patient did not achieve flaccidity for the last 6 hours, and he has come back to you again ever since the injection. So basically we've already discussed what are the constituents of ICI VAD. So we know there's a bimix that we use, there's a trimix that we use. Now the advantage of a trimix is that the chances of this kind of a situation happening, which is the next question, what is this condition? This is called priapism, because we are not able to get the penis back down for such a long time. It's been more than 4 hours. So this is priapism, and trimix causes less priapism and it's more effective. But the problem with trimix is that it is more expensive, since it has alprostadil in it. It requires a cold chain, and it may have a painful injection because of alprostadil. Biomix, on the other hand, is cheap and it can be stored anywhere in any part of the refrigerator except for the freezer, and even at room temperature, without really causing a disturbance in the effectiveness of the drug. So this condition is called priapism. And now how would you like to manage the priapism of this patient? So whenever we are giving an intracavernosal injection of vasoactive drug, we have to tell the patient that we are going to make this injection, and there could be some complications. So what are these complications? There could be local complications, like there could be a hematoma, there could be an infection, there could be inadequate dosage, because sometimes the injection may not go deep enough, the patient may be phobic, needlophobic, and they may just make a superficial injection, so they may have no effectiveness. This is again a complication only because the couple is waiting to have intercourse and they are not getting the desired result. And there can be some sort of a fibrosis which can happen because of the repeated trauma by the needles, and especially if it's not put in the right way at exactly 90 degrees to the corpora, then sometimes it can cause more trauma while injection. And there could be other complications like systemic complications, which will be because of the drug going into the system, which could be hypertension, cardiac problems, issues related to the sensitivity to the medications, and there could be priapism. So we have to tell the patient that there is a chance that this erection which comes out after the intracavernosal injection of the vasoactive drug, it may not go, and then it requires some sort of an intervention. Now typically if there is a priapism, there is a algorithm to work around it, because priapism, as we know, can be of various types. So most importantly, we classify it as high flow and low flow. Now high flow is basically an priapism which happens because the blood is coming in and it's not able to go out. So in both of these types of priapism, we have to try and identify what is the priapism we are dealing with. So basically whenever there is a low flow priapism, what is going to happen is that the blood is going to come in, but it's not going to go out, so it's going to stay. So in this kind of a situation, there is going to be low saturation of oxygen in the sample of blood that we withdraw from the penis. Whereas in high flow, what is happening is that the blood is coming in and it's going out as well, but basically because of the local fistula which has formed, such as a AV fistula, there could be high oxygen content in high flow priapism. So typically we will also find that in high flow priapism, the carbon dioxide content will be less and it will be more towards an alkaline side, the pH, whereas in low flow priapism, it's going to be high CO2, and because of this high CO2, there's going to be acidity. So that's how we will be able to differentiate whether it's a high flow priapism or a low flow priapism by just doing a blood gas analysis of the blood which we have withdrawn from the corpora, which is presently turgid. Now, in this kind of a situation, since we already know that we've given an intracavernosal injection of vasoactive drug, so we are expecting it to be a low flow priapism, because what has happened is that the blood is coming inside from the arteries. It has already compressed upon the surrounding veins. These veins are now compressed, and this blood is now accumulated within the sinusoids, and it's formed a kind of a clot there. And this blood then needs to be removed. So what we typically do is that we aspirate the blood from the penis. Meanwhile, to be sure that there is no other cause, we can get a Doppler ultrasound of the penis to see whether there is any arteriovascular fistula or AV fistula as a cause. Now, once we aspirate, we send the analysis. Once we aspirate, what is going to happen is that the veins, they are going to deocclude. They are going to get some space so that the blood can start to flow back and the things may return to normalcy. But many times, because there has been so much of lactic acid there, there is so much of acidosis there. So what is going to happen is that the veins are still going to remain collapsed, and the sinusoids, they are still going to remain filled with blood, because the arteries are still dilated, so blood can keep coming in slowly, and it becomes difficult to achieve a detumescence with simple aspiration. Now here what we can do is we can irrigate the entire sinusoidal structure, so that what happens is that all the acidity is washed away, and at the same time any other metabolites which are there are washed away. Any clots, they also get dissolved and are washed away, and this can lead to a return of the normal flaccidity of the penis. Now, in case this also doesn't happen, then we can give a agent such as an adrenergic agent like phenylephrine, so that the arteries, they become a little constricted, and basically the blood flow reduces, as well as there is an increase in the outflow. So this kind of a sympathetic agent can be helpful. We can also give very diluted adrenaline also if required, but it has to be done with caution, because penile artery is an end artery, so it has to be super diluted adrenaline. Now, considering that even after this irrigation with phenylephrine it doesn't work, then what we can do is we can create shunts, which can be distal shunts or proximal shunts, depending on how effectively we go from one to the other. And this is most about priapism. Typically, a priapism which happens because of the injection of a vasoactive drug doesn't last that long. Typically, what will happen is that once we remove the blood, and maybe if we do some irrigation, the flaccidity is going to come again. And this aspiration has to be done with a wide bowl needle, typically at least a 21 to 16 gauge needles. They can all be used to drain the blood. So that's about the test which we need, which is a blood gas analysis or an ultrasound, and treatment would be to aspirate. So now, once this couple has undergone this painful experience with an ICI VAD, they are not wanting, or they're not interested in using this as a therapy for their sexual activity. So patient wants to consider a permanent treatment for the erectile dysfunction, which is something which has high success. So basically now we come back to the point where we had talked about the therapies, and we already know that PRP and low intensity shock wave therapy, they are not very effective treatments. So what we are left with is a penile prosthesis. So let's learn about penile prosthesis. So which implant would you like to offer to this couple? What are the types of implants? So let's learn about the types of prosthesis. So as we know that there are two main types of prosthesis. One is the malleable prosthesis and the other is an inflatable prosthesis. So malleable prosthesis basically are the ones which cannot be inflated or deflated. They remain in a particular size. So they are all silicone based. But they can again be of two types. One with a memory, which means that if you bend it, it will remain bent because it will have something like a wire in it. So because of this wire, when you bend this prosthesis, it will remain bent. And the others are without a memory, where there would not be any substance in them. Inflatable ones are the ones where we have just a silicone cylinder and water fills into them through a pump, and depending on whether it's just a pump and the cylinders, we can call it two-piece prosthesis. And if there's also an additional reservoir in it which goes into the abdomen, then this is called a three-piece prosthesis, because there are now three pieces which are being joined to each other to produce an erection. So basically, in a young couple where they want to kind of have a very long life with the prosthesis, malleables are the ones which are technically something which lasts longer, and they have less risk of mechanical failure. But because of the problems with concealment, because this penis is always going to be erect if there's a malleable prosthesis in it, then many patients may not like to choose a malleable prosthesis. They would like to choose an inflatable prosthesis, because this inflatable one can be deflated and the penis will return back to a flaccid state. It will not be as flaccid as it used to be in a natural way, but it will be definitely much more concealable and much more comfortable for the patient. So the limitations, as we discussed, are that the malleable prosthesis will require some sort of a concealment option. So they would require tighter underwears or pads, and they have to be socially aware because it can lead to embarrassing situations. And from that perspective, the inflatable prosthesis, they win over the malleable most of the times as the gold standard for treatment of erectile dysfunction, which is refractory to medication or any other therapy. Now, the problem with inflatable prosthesis is that there are a lot of parts in this. There is a fluid system which is going from the reservoir to the pump, and then from pump to the cylinders. So there is a good chance that there could be a mechanical failure in these patients because of the things not working properly, or the buttons or the pumps not working properly. Also in patients where they are not able to pump, for example, the patients would have no manual dexterity. There also we cannot use the inflatable prosthesis. So anybody who is looking for longer options, the ones where there is less of mechanics involved, less of complications involved, less of incisions involved, we would like to go for a malleable prosthesis. Otherwise, if somebody wants the natural erections, something which can deflate also, and is not worried about the cost factor because inflatable are much more expensive than the malleable ones, then we can choose the inflatable prosthesis as the gold standard. Now, how will we counsel this patient? Of course, we will tell the patient the pros and cons, the types. So we'll talk about inflatable, the malleable, and then we'll tell what is better. And typically we let the patient choose in this situation what they would want to choose based on their economics, most importantly, the concealability, and lastly the comfort of the device. Now this patient, we underwent a two-piece penile implant. Now two-piece penile implant, as we already saw, there are going to be two cylinders in it and there's going to be one pump in it. Now, the mechanism by which the two-piece penile implant acts is that there is a reservoir at the back of the cylinders, and from those reservoirs, the water is pumped into the front of the cylinders. So, the patient is able to achieve a flaccidity by bending the implant, and whenever they want to inflate the implant, they just have to press the scrotal pump. This pump is lying in the scrotum. Now, basically, he had a good married life, and now he presented to you with inability to inflate the implant after 6 years. Now, basically, what are the possible problems that this patient has had? So, already we know he had a tormenting journey. He tried medicine that didn't work. He tried to do the intracavernosal injection, but it led to priapism. And now he underwent a penile implant, the successful implant. But then after 6 years of using the implant, he is now not able to inflate the implant. So, basically, it means two things. Either there is a problem in which the patient is using it, which is very rare because now for 6 years the patient has been using the implant. The other thing could be that there is some sort of a mechanical failure. So, the inability to inflate means there is a mechanical failure in the device, and for that we need to examine the patient. We have to ourselves try and inflate the device. Now, since the patient was called and we checked the patient's device, it was not working. The pump was pumping, but it was not inflating. It was almost collapsed, which meant that somewhere down the place the fluid had leaked from one of the tubes, and it would have collected around the implant and now got absorbed. So, now the pump is basically almost deflated. So, if we try to press it, there is no fluid in that pump, which means that the fluid has all gone out. It has leaked from somewhere. So, it could be because of trauma, it could be a penetrating trauma, it could be a leak because of wear and tear of the device, which is an acceptable thing. Now, how would you like to manage this case further? So, already we know that there is not much of a guarantee for these implants. They are in India, it's about 5 years. So, in case this happens, what we have to do is that we have to change the implant. Now, in this situation, we have to counsel the patient that this mechanical failure has happened. It can happen with any device because it's a mechanical device, and we have to go for the only option, which is to remove the implant and put in a new implant. Why we have to remove the implant and then put in a new one is because if we don't put an implant back again, then there is no sinusoidal tissue in the corpora cavernosa anymore, and the patient will not be able to have intercourse. Now, if we don't replace the implant immediately or within some time, then what is going to happen is that eventually the fibrosis is going to start and the penis is going to shrink, the corpora cavernosa, they are going to shrink, and ultimately we will not be in a position later to place any implant. So, what are the complications of the implant? That is something very important to know, because when we counsel the patient, we have to tell them about some complications. So, there are immediate complications and there are late complications of any implant. Now, the immediate complications are that, one, there could be infection, which is one of the most dreaded complications. So, once there is infection, what is going to happen is that we will need to remove the implant, we will need to irrigate the area with antibiotics and wait for about 2 months, at least 6 to 8 weeks, or sometimes as much as 12 weeks to put in a new implant. The other thing which can happen immediately is perforation. Perforation means that we are going to have our dilators going into places where they shouldn't be going. So, it could either be a proximal perforation, which is in the back side around the pubic area, or it could be on the front or distal side into the urethra, or outside from the corpora into the skin or subcutaneous tissue. And these distal and proximal perforations, both of them have their separate management, and we'll discuss about them further as the case progresses. Apart from that, the immediate complication can be urethral injury, which means that sometimes we may injure the urethra while we are dilating, and here you will have to abandon the procedure. Apart from that, the immediate complication could be migration of one of the devices. For example, there could be migration of the scrotal pump upstairs, there could be migration of the reservoir from the abdomen extraperitoneally into the superficial tissue. So, these kind of immediate things can happen, especially if there is violent cuffing, or if the placement has not been adequate, the space creation has not been adequate, or if there has been no fixation around it, around the tubes with the suture. So, these kind of things can happen. And also there can be hematoma formation, which can again become infected. So, that is also one of the immediate complications which can happen with the implant. Sometimes you may have immediate failure of the implant, because while putting the implant, maybe our surgical needle punctured the implant or something on those lines happened, or it was actually a faulty implant and there could be a failure of the device as well. So, these are some of the immediate complications that the patient should be aware of. They should be aware of that after putting an implant, there could be reduction in the size of the penis, in the girth and in the length as well. And this could vary, say, from about 0.5 centimeter to anywhere about 2 centimeters. So, the patient has to be told that it's a cosmetic procedure and they may not exactly get what they're looking for. In fact, there is going to be possibility of all of these complications, and only if the patient is willing to accept the complication of the surgery should we go ahead and do the procedure. Now, talking about the late complications, again the late complications could be infection, wherein there is a chronic infection and it is slowly eating away, and it leads to something which we call as the erosion of the implant. So basically what is going to happen, if there is going to be undue pressure over the natural tissues, then the implant can slowly cause ischemic necrosis of the tissue, especially if there is an infection. It can erode into the normal tissue and the implant can protrude out through the skin and subcutaneous tissue. So this is something that we have to be talking to the patient about, that they have to be careful when using the implant. Apart from that, there could be again problems related to mechanical failure of the implant, and sometimes there could be displacement of the implants back, and that could lead to a floppy penis and other kind of things. So these are complications which are around the response of the body to the implant. We are of course not talking about complications which happen because of the inexperience of the surgeon or wrong placement of the implant, or because of the shortening of the length of the implant, or putting oversized implant zealously. So those kind of mismatches can lead to either something which we call as the concord deformity, wherein if the implant is shorter than the penis, then the glans is going to droop, or it could lead to S-shaped deformity of the penis because the implant would buckle inside the penis. So this is S-shaped deformities because of the increased size, and concord neck deformity or concord nose deformities because of the poor size, and this has to be differentiated from floppy gland syndrome. Floppy gland syndrome is a different thing, wherein we have poor supporting structures to the glans penis. So this is something that you have to talk to the patient about, and what has happened here is clearly mechanical failure, which is bound to happen anyways after 10 to 12 years most of the times, and it has happened just a little bit earlier. Now, patient wants a revision of the penile implant after mechanical failure. He would like to choose a more durable implant. So which is a more durable implant now is probably a malleable implant because it is not prone to mechanical failure. And the patient is now okay with the issue related to the concealment of the device. He understands that he will have to take some special precautions and measures to conceal the device. But during reinsertion, when we put the antibiotic solution into the corpora after removing the implant and dilating the thing further to put a adequate sized implant, there was leak from around the catheter. Now basically, what does this leak from around the catheter indicate? Of course, it indicates that when we put in the solution in the corpora, there was a rent from the corpora into the urethra, because of which the fluid which was put into the corpora came out from the urethra. And this is basically a urethral injury. Now, how do you manage it is that you immediately stop the surgery. You don't do anything. You let the rent heal on its own, and you come back again maybe a few weeks later. Now, apart from that, what are the other challenges that can happen when you are doing a revision? First and foremost, the most important challenge is that there is going to be a higher rate of infection. So you have to understand that while the infection rate is only 1% with a native implant, it rises to as much as 10% when we are doing a revision of an implant. The other important thing is that these tissues, they are going to basically not be as healthy. They would be also sometimes ischemic. So you have to not dilate overzealously. You have to basically be very patient and gentle with the tissues and try and put the original size that you have removed only without any further dilatation if the patient is quite okay with the previous size that the patient had. Apart from that, the challenges again are fibrosis. Sometimes there could be some injuries which can happen more commonly, like urethral injury as we saw in this case, or maybe a more proximal perforation at the backside. But apart from that, because it's a simpler surgery, we are just removing the implant and then we don't have to dilate, so it is done quickly. And most of the time, if the surgeon is well versed, they can probably find it easier to replace the implant than to put a new implant. So this was an interesting case where the patient had to go through a long journey for treatment of erectile dysfunction, and we could discover a lot of concepts around erectile dysfunction, its evaluation, its initial treatment, the ICI VAD therapy or intracavernosal injection therapy, priapism and complications of ICI VAD, the penile prosthesis, the types and the complications of penile prosthesis, and some tricky scenarios around it,